Crohn's disease, one of the family of inflammatory bowel disease, which include Crohn's and ulcerative colitis. Crohn's is a chronic inflammatory disease of the gastrointestinal tract. Inflammation extends all the way through the intestinal wall, from mucosa to serosa. It has a relapsing and intermittent course. Initially starts in a small segment of the gastrointestinal tract, but has the potential to progress extensively through the gastrointestinal tract. Incidence of the disease, it usually appears early in life. Average age of diagnosis is 27 years old. Distribution: 1/3 of the patients shows a gross pathologic change limited to the terminal ileum. About 40% have ileocolitis, involvement of the distal ileum and proximal colon. There is either continuous involvement throughout the bowel or, more common, several sharply demarcated skip areas separated by normal bowel. Most patients have focal mucosal inflammation, which can be seen endoscopically, and scattered abscess ulcer, visible macroscopically scattered throughout portions of otherwise normal bowel. Crohn's disease is more likely to cause fistula, benign fibrous stricture, and perianal disease as perianal fistula. The causes of Crohn's disease: there is no unified hypothesis that explains the pathogenesis of Crohn's, but possibly there is an infectious agent or antigen from intestinal lumen, possibly intestinal bacterial flora, that sets up inflammatory response in genetically predisposed host who cannot downregulate it. So this disease may be clustered in certain families. Presentation of Crohn's: most patients present with abdominal cramps, diarrhea, delayed growth, especially prepubertal patient, weight loss, fever, anemia, right lower quadrant lesion, or perianal fistula. The clinical picture depends on the areas of the bowel that are involvement. Crohn's may be associated with extraintestinal manifestations, which may be more problematic for the patient than the bowel disease, as migratory arthritis or primary sclerosing cholangitis. The diagnosis of Crohn's disease is established by combination of clinical, radiologic, endoscopic, and pathologic findings. Radiographic diagnosis: contrast barium enema visualized through CT or X-ray show abscess ulcers as a small filling defect with opaque center, or loss of normal mucosal detail, couple stone filling defect, segmental areas of involvement, or fistula. By endoscope, by flexible sigmoidoscope or colonoscope with biopsies can reveal focal inflammation with granulomatous, even the patient has no gross findings. Pathologic diagnosis: under the microscope, it shows non-caseating granulomas as rounded collections of inflammatory cells, about 30 to 50% of the resected bowel sections. The pathologic findings correlate with 3 distinct disease courses. The inflammatory types, where inflammation localized is limited to mucosa and submucosa. This presents clinically with diarrhea and abdominal pain. Fistulizing or perforating type is more aggressive transmural inflammation that cause intra-abdominal fistula between diseased bowel wall to another loop or nearby organ or even to skin. Sclerosing or stricturing type causes painful cramps and requires surgical intervention. This is chronic mucosa with under the mucosa rounded collection of inflammatory cells forming non-caseating granuloma, which may be present in Crohn's disease. Differential diagnosis: other diseases with same distribution as ileocecal tuberculosis, yersiniosis, lymphoma, carcinoid tumor, amyloidosis, and or even cancer of the cecal. Treatment of Crohn's: mainly medical treatment as anti-inflammatory drugs, antibiotic, immunomodulator, diet as elemental diet composed of simple sugar and amino acids that do not require digestion. Complication: abscess or fistula due to extension of mucosal fissure or ulcer through intestinal wall into another loop or extraintestinal. Terminal ileum is the most likely point of origin for abscess. Fistula may be enteroenteric or enterocutaneous. Obstruction, especially in the ileum, and this is common complication, one of the major indications for surgical intervention or endoscopic balloon dilatation. Prognosis: patients with Crohn's disease today have excellent prognosis for long-term survival and acceptable quality of life. Most patients managed with current standard medical and surgical approach report a good quality of life. Thank you.